Hi, welcome back to Your Body. We are still in New York. We're still at East 77th Street, Lenox Hill Radiology. And we're going to talk today about cardiac disease, which I know we've talked about before, but this is such an important topic. You know, heart disease is the leading cause of death in the United States for men, women. Every year, about 805,000 people die of a heart attack or have a heart attack, actually. And 49% of people ages 40 to 65 have coronary artery disease. And 77% of patients are hospitalized with heart disease and have what is considered normal cholesterol. So these are staggering numbers. So it's definitely worth getting into more. So I'm excited to talk to my guest today, Dr. Robert Peters, who is a cardiac radiologist. Hello. Thank you for joining me.
Thank you.
Before we get into it, let's talk a little bit about you. So your personal background. So tell us a little bit about your journey into medicine and cardiac radiology. Let's get into it.
All right. Well, I am a graduate of Stanford University in molecular biology and biological sciences, and I attended medical school at the Medical College of Wisconsin, then attended an internship at NYU, downtown hospital. I did my residency at UCLA Medical Center, where I was chief resident, and I then did a fellowship in body MRI and cardiac MRI at Johns Hopkins.
Okay.
And when I was in training, really this particular test, I think we're going to focus on, the cardiac CT test, wasn't really available.
Right.
The scanning equipment wasn't capable of doing it, and so it was very unusual for radiologists to have cardiac experience, because most cardiac procedures and diagnosis was performed by cardiologists.
Okay.
However, as a cardiac MRI fellow, I had some of this additional training. So when cardiac CT became something new because of the scanner technology, I then moved on into cardiac CT as well as cardiac MR.
Right. And what interested you specifically about cardiac?
The heart, I think, was something that that typically wasn't trained heavily in my residency program. So it was unique. Because the heart is the sort of the one of the moving organ. It's beating.
Yeah.
It's very complicated to get a good image. And so using the technology that we had, either MR or CT, to freeze the cardiac motion so we can make diagnosis was intriguing to me.
Right. That's super interesting. So like, as we talked about, it's so common, heart disease, cardiovascular disease, and traditional testing has been right?
Yeah.
So now comes along imaging, and it's really evolved, like you just mentioned. Like, can you talk more about how it's evolved and how it's replacing traditional imaging?
Yeah. So prior to around 2000, so maybe a little bit before, a little bit after, when this technology became available, the only way to screen for significant coronary artery disease, that is the disease that causes heart attacks, was to perform a stress test, which is an indirect test. It's a test that looks at how much blood flow gets to the heart muscle. So it indirectly shows what's going on, because really what we want to know is what the plumbing is like.
Right.
If you think about the heart, it's sort of like a car. It has an engine like a muscle, which is the muscle, It has valves, it has plumbing, which are the arteries, and it has an electrical system. So really the thing that causes heart attacks, which is the number one killer, are blockages in the arteries of the heart. So when you do a perfusion study or a stress test, you're looking at the end result of the blockage. You're not looking at the blockage directly. So with the CT scan now, we can look at non-invasively, look at the blockages directly and look at the plaque directly. So that's where the level of sensitivity increased greatly. So we were able to pick up a lot of coronary artery disease that was not detected by stress testing and not detected by clinical assessment. Like, do you have high cholesterol? Do you have hypertension? Are you a smoker? Do you have a family history? All that stuff was good, and that's what we had. But now we can look directly.
Yeah, yeah. And there are different kinds of CT scans for the heart, right? Different levels or different types.
For a CT scan of the heart, it's pretty much one type of scan.
Right.
There are some slight variations that we can look at the valves and we can look at some other parts of the heart function, but primarily its primary utility is to visualize the arteries.
Right. Okay. So I know there's the CTA, which is like your first.
This is for the coronary arteries.
Right.
Yeah.
And then after that, there's a CCTA. Is that right?
That's the same thing.
It's the same thing.
It's just cardiac CTA. And then you just reduce the.
But what about when you add like FFR? What is that?
Okay, so that.
I wrote a ton of stuff.
Right. Yeah. That's a great question.
Yeah.
So the CCTA, or cardiac CTA, which is just a contraction of that.
Yeah.
That's the scanning that is performed to acquire the volumetric data. We make basically a virtual 3D model of your heart with a scanner.
Okay.
So I can pull out the scanner and show you the pictures, and you can rotate it, and it looks like your heart. It is your heart. It's just a 3D model.
So cool.
It's incredible.
Yeah.
Going back to why I do it, because that's really cool,
yeah,
right?
That's so cool.
So that is really the crux of the scan. And then I can look at it and I can decide, what's going on. Okay. Is there blockages? Are there no blockages? Does the muscle look healthy? Do the surrounding tissues look healthy? The lungs, the pulmonary arteries, that sort of thing.
Okay.
The rest of this that happens, for example, FFR, is a post-processing analysis. So what's been found is that everybody talks about blockages.
Yeah.
How much is your blockage? Oh, you have a bad blockage. We have to open the blockage. Well, it's more nuanced than that. Really, it's about flow.
Okay.
And so what the FFR does is it's a post-processing, post-data collection analysis that looks at the flow through the artery.
Okay.
So you can have a very bad blockage, but good flow. Or you could have a very mild blockage and have bad flow.
Okay.
So it's more nuanced than that.
Right.
And then on top of that, we have even come a step further to look at plaque analysis. So the buildup of the material in the arterial wall now can be analyzed for its component parts.
Wow.
Because the idea is that then if we treat the patient, we can watch the artery heal. Something that has never been able to be done before.
That's so cool. And it can heal.
And it can heal.
It can heal.
Yeah.
So who's a candidate for this kind of screening? Like, who would want to go have this?
We have to look at your clinical characteristics.
Okay.
Clinically, what is your risk?
Okay.
And that can be assessed by a clinical algorithm that is used by the AHA and the ACC. Those are the American Heart Association, American College of Cardiology.
Okay.
Looking at your risk, then using this assessment tool, you can decide whether or not a test is useful to then more refine your risk. Because what we've seen is quite a number, a very large majority, sometimes as much as 50% of people are misinterpreted by this clinical algorithm. So in other words, the clinical algorithm goes back to those same things we just talked about. How do you have high cholesterol?
Right.
Do you have high hypertension? Do you have
Mm-hmm.
a family history? Are you a smoker?
Right.
Some people have none of that. They
Yeah.
have normal cholesterol. They have no family history. And despite all that, they have bad blockages.
Yeah.
And so sort of there's a little bit of a, again, this is a practice of medicine. So you have to kind of take into the whole the whole person and decide who needs this test.
Yeah.
And who doesn't need the test. Certainly if there's any signs of symptoms, this test is indicated.
Yeah. I mean, I did just get an order for it from my doctor. I'm a certain age and I have high cholesterol. It's just like genetic because, I do eat pretty well. And my father had high cholesterol and he had a heart attack. So she was like, you need to just go get it done.
Exactly. And so now instead of kind of saying, oh, well, let's just give you some medicine.
Right.
Let's see what's going on.
Yeah.
Because there is a chance that when we look at your arteries directly,
mm-hmm.
they're going to be fine.
Right.
And then we have to have a discussion about what to do about your cholesterol.
Right.
And in some instances, you won't need cholesterol medicine. If in fact you do have plaque, then you're going to feel very good about taking the medicine.
Yeah.
And I think that's the other side of this that's very unique is that a lot of people take this medicine because somebody says you have high cholesterol.
Right.
And so you think you're dealing with your cholesterol. You're not. You're dealing with your plaque. And if you can show somebody, look, you've got plaque.
Yeah.
How more powerful is that?
Absolutely.
Right.
All right. It's not different than you have a lump in your breast or, right? Because it really is like the beginning of something that could kill you.
Right.
Right. So.
And so this way we can look directly and know what's going on.
Yeah.
Let's say instead we did the stress test. Let's say you had the stress test.
Yeah.
The stress test only becomes abnormal if your blockages are 70 or 75%. So you're going to miss everybody that has just a little bit of plaque, and you can't. And so now you can tell people, listen, you got a little bit of plaque. It's not 75%.
Yeah.
But if you wait 10 years and your cholesterol is bad, it may be 75%.
Right. And it's sort of like what we're always talking about, which is early detection. Right.
Right. And as I always tell people, this coronary artery disease thing, this cause of heart attacks, is a preventable disease.
Yeah.
So if you know, you can prevent it.
Right. Yeah. So what was that stress test? I mean, I don't know that I ever had a stress. Was it when you just walked on a treadmill and they monitored your heart?
That's one of them. And then you can do an echo stress test, echocardiography, where you exercise and then they put the probe on your chest, the ultrasound of the heart, and they look to see how well your muscle squeezes. And the third one is the nuclear stress test, where they inject a radioactive substance into your bloodstream.
Yeah, because the one where they just watch your heart, I don't know how they could tell anything from it. Really. I mean,
these are just stages of evolution. Like that was the earliest test, probably. I don't know if you could, I'm not sure, but let's just say that test is 50 years old. Okay. The nuclear stress test is probably 30 or 40 years old. And like I said, this coronary CTA, the CCTA is about 20 years old.
Yeah. So this is something I think more people should be aware of.
Yeah.
Right. And talk to their doctors about. People can bring it up. If their doctors don't bring it up, they can bring it up to their doctor.
Right.
Right. You have to be proactive about your own health. So another thing I wanted to actually talk to you about a little bit specifically is regarding women and heart attacks. Because not just because I'm a woman, but also because it is also the leading cause of death for women, specifically in the United States. 1 in 5 female deaths are from heart attack. And yet women don't actually recognize that this is their leading cause of death. And a lot of the symptoms for women when they're having a heart attack or on the verge of a heart attack are so different than what we traditionally think of as a heart attack, and they don't really recognize it. So
yeah, all those things you're absolutely right.
Yeah.
And historically, we've always thought of men having the heart attacks, and so women just don't think of it.
Yeah.
as much. And to your point, is the clinical presentation is completely different.
Right. Right.
And so in many instances, women will walk into their physician's office and say, I'm having maybe some neck pain
Right.
or some arm pain or
Mm-hmm.
some indigestion or
Yeah.
fluttering. And, you know, prior to this test, there wasn't a good way to really figure out what's going on. And
Yeah.
now we can.
Yeah. But that's the thing, is that I wonder how many doctors will recognize that it could be a heart issue also, or even, women, because I feel like women, we're used to having a lot of like weird little aches and pains that we just kind of like, it's just another little thing.
Right. And so it, it's this again, this is a very easy test to perform if you know to perform it.
Yeah.
And so, yeah, if people have those types of symptoms, they can self-advocate
Yeah.
for some additional testing that defines what's going on in their arteries.
Yeah.
And, and then again, depending on what is found,
Right.
you can be treated or you could be reassured.
Right. Right. Yeah. It's not like you don't have to think of your life like, well, my dad died of a heart attack at 60. So that's just the way it's going to be for me. Right. You don't have to think like that.
That's right.
That's fabulous. I mean, that's encouraging, right?
Yes.
Absolutely. So let me ask you this question. So you are a fellowship trained cardiac radiologist. So what is the benefit of having your screening read by a specialty trained cardiac radiologist versus someone with just general radiology training?
Well, kind of going back to a little bit of what I said earlier is that at least now, at least prior to maybe 5 years ago, cardiac radiology didn't really focus on the heart as much in terms of training. And that's because, we didn't really have the tools in radiology to do the type of analysis that we can do now. And so there's fewer people that are trained in the evaluation of the heart.
Mm-hmm.
And so if you're going to have this test, you would want to go to a place where a practice, a location where they have an active program that really has somebody that's running the CT laboratory and monitoring the patients properly, and then interpreting the study with the additional knowledge.
Yeah.
This test is very much, it's unlike a lot of types of other imaging tests, we really have to prepare the patient.
Okay.
So it's a little bit more involved than, let's say, just walking in and having a head CT.
Okay.
Or having a mammogram. There's a little bit more preparation.
What is that prep involved?
That prep involves sometimes taking a medicine called a beta blocker.
Mm-hmm.
It's called metoprolol generally, and that medicine reduces the heart rate.
Oh, okay.
The reason for that is that the more relaxed the heart muscle is, we get better motion-free imaging.
Okay.
If your heart rate's very fast, just like a camera, and let's say you're trying to image, a car going around a racetrack at 150 miles an hour, you need a fast camera to freeze that car.
Right.
And so that's a similar thing. So by using the medicine, we can relax the heart muscle. The heart muscle, the heart beats slower with this beta blocker. Okay. And then we can get a good image of the arteries. And then the other medicine that we use is nitroglycerin. And everybody's like heard about, grandma and grandpa had nitro and they got a little chest pain. They had to pop a couple tablets.
Right.
That was like what a lot of people remember. We use it for the same reason, to dilate. And the reason why grandma and grandpa took the nitroglycerin was to dilate the artery, to allow more blood flow to the heart muscle so the pain would go away.
Oh.
So we use the same thing. We use the nitroglycerin to dilate the artery so we can see better into the tube.
Interesting.
Yeah.
Oh, okay. So it's a little prep. And how long before the test do you have to take those things?
Typically, we have patients, it depends, but typically patients come in an hour before the actual test. Mm-hmm. The majority of the time you spend in the office is this preparation. The test itself is 5 minutes.
Oh. Yeah. Well, that's good. Yeah. That's good to know. And then let me ask you, regarding like the beta blocker specifically, are there side effects to it?
Yeah, there are side effects to beta blockers. The fact is we use beta blockers just a small focal dose once. Mm-hmm. And that over the next 6 to 9 hours, the beta blocker goes away. Mm-hmm. And so there rarely is any side effects because we're only using it just once. Right. Most side effects in most medicines tend to happen after you've taken them for a long time and the medicine has built up over time. Right. I'll be honest, it's very rare to have an issue with beta blockers, but it can drop your blood pressure. Mm-hmm. We give fluids. We give IV fluids in those instances. Mm-hmm. Mm-hmm. And it can slow your heart rate down temporarily. And usually it's, drops your heart rate from 75 or 80 to 60. Right. So maybe you're a little tired. Very, very, very rare. Yeah. That there's any kind of side effects to beta blockers. Right. And it's a very common drug that's been around for a very long time. Yeah. I think they used to give it for migraines, didn't they? They give it for stage fright. So when somebody has to give a talk, really, like me, I should be taking it now. But it's like an anxiety drug, really? Well, so because it slows palpitations. Oh, okay. So if you're giving if you're giving a speech, and you get up there and you're like, and your heart's cranking, if you give some beta blockers. So surprisingly, even people I've heard of people presenting at the Oscars take them. Really? I always joke with my patients. I'm like, maybe if you want to improve your golf game, you're a little stressed out. Yeah. So yes, correct. It's migraine headaches. It can be related to palpitations. So let's say if you have atrial fibrillation, or an arrhythmia, it can be anxiety, but it doesn't affect your cognition like a benzodiazepine would, like Xanax. Right. And then of course it's for blood pressure and heart rate control. Yeah. It's really fascinating just to see how it's all evolved. How do you see it evolving moving into the future? Well, so going back to all this post-processing analysis. Mm-hmm. So now that after we have a 3D model of your heart, a virtual, your heart in virtual space. Yeah. What we're finding is that data can then be analyzed beyond what I would say just a radiologist can interpret. And that's because computers are just so much faster and better at analyzing certain parts of the anatomy. Mm-hmm. So going back to, and this is very, very new stuff. So within the last year, maybe 2 years, where we're able to actually determine what is in your artery. Before, let's say, the last few years, it was very difficult for me to say, hey, you've got plaque, but I don't know what kind of plaque it is. Right, because there's different kinds of plaque. That's right. Uh-huh. And so now, not only can we quantify or locate the plaque and how much it's causing a narrowing, but we can determine what type of plaque it is. And why is that important? Because heart attacks, again, like I sort of alluded to earlier, heart attacks happen not necessarily in the worst blockage. Mm-hmm. It's the 40%, 50%, 60% blockages where essentially the plaque ruptures, almost like a volcano. Oh. And when it kind of blows up, or like how about a pimple? It's like a pimple, right? It kind of blows up and it causes thrombosis in the artery. And that's what is the real cause of this acute coronary syndrome or heart attack. And that can happen not in a 90% blockage. A lot of times those are old blockages that have been there for so long that they're not going to blow up.
Okay.
So the heart attack sometimes occurs in plaque that tends to be what's called more vulnerable. It tends to be more fatty filled and cholesterol filled. So if I can quantify the amount of cholesterol, fatty plaque, I can then say, listen, this is what we're dealing with. And then again, coming forward is that now if you treat the patient with a cholesterol lowering medicine, many people take it, and we can watch then that plaque change into chronic stable plaque and not vulnerable plaque.
Okay. So the plaque can remain, but it's not like gonna explode.
Typically we don't see plaque regress.
Okay.
But we see it heal over, sort of like a scar.
Okay.
If you have a scar, the skin is changed.
Yeah. Okay.
And that's what you're doing. But the integrity of the artery remains.
So interesting. Yeah. So cool. What about, I wanted to ask, this is not like cardiac disease, but like someone who has like a cancer in their heart. There's something I just recently heard about. I didn't even know that was a thing.
Yeah. CT can be used for looking for masses in the heart. Typically that is the cardiac MR. That's when I put on my cardiac MRI hat. And we do a specialized test that looks at, where the mass is and what's it doing, and if it's taking up any of the contrast, it has any vascularity.
Yeah.
But CT is possible to do that as well.
Right. That's not very common, is it? For cancer to spread to
it's not very common.
Yeah. I didn't think so.
Yeah.
Wow. Okay. So in terms of the evolution of cardiac imaging, so do you think it'll be even more able to, I
think
find things?
I think now that we have, we can visualize the arteries directly. We can analyze the plaque. We can really then take you as a person and come to, really give you an idea of what your risk is.
Yeah.
And then we can treat that risk and reduce it with medication.
Right.
And then we can show that the medication is working. There are some instances where people will take a cholesterol medicine and it won't be enough.
Right.
Now we have other medicines that we can use that are in addition to the typical cholesterol lowering medicine that everybody's like Lipitor and Crestor, those things.
Yeah.
We now have other classes of medications that can be used. And again, this is only in the last decade.
Right.
So a lot of things are changing in terms of diagnosis and then treatment of coronary artery disease.
Because that's what I was going to ask, if the medications have caught up to the imaging.
They have, and now we can watch it just like anything. The change is what's important. How are you changing over time? So I always tell people, whenever you have a radiology, any type of imaging, acquire those images and keep them in your personal records.
Okay.
Because you'll never know when that information will be useful. It's massively useful.
Yeah.
Because, one of the other things we see quite a lot of are people who have aneurysms of their aorta, which is the large vessel that comes out of the heart.
Yeah.
And that's another thing where the cardiac CT, the CCTA, is able to measure with high fidelity an area where an aneurysm can occur. So not only are you being screened for your arteries of your heart, but we also see the major artery coming out.
Wow.
We can also assess your risk for an aneurysm. So the aorta is the major artery that supplies your entire body of blood.
Right.
So it comes out of the heart.
Yeah.
And it goes straight up, like towards your brain, and then makes a huge turn and goes straight down to your legs. there are basically two major parts of the aorta. One's the thoracic aorta, the aorta that's in the chest.
Right.
And the other is the abdominal aorta, which is the aorta that's in your abdomen and pelvis.
Mm-hmm.
And the triple A is the three A's are abdominal aortic aneurysm. That's atherosclerosis causing an aneurysm, but in your abdomen, so below your chest.
Okay.
You can also have a thoracic aortic aneurysm or a TAA.
Okay.
So a triple A or TAA, thoracic aortic aneurysm. That aneurysm occurs at the base of the heart and in the proximal portion of the aorta before the vessels start to branch off.
Oh, okay.
Except for the coronary arteries.
Okay. Okay.
And, if you've ever heard of an aortic dissection
Mm-hmm.
or a ruptured aneurysm of the aorta,
Yeah.
it's something that is a risk factor, just like atherosclerosis
Yeah.
of your coronary arteries. And so you could have like fine coronary arteries, like, not huge blockages, but you
Yeah.
could have a big aorta. And if that aorta is not fixed, you could have a rupture.
Okay. So this is something also that can be detected.
So that's also, yes, that's
Yeah.
also detected with this
Yeah.
CCTA, cardiac CTA.
Okay. So what about calcium?
There are two flavors the CCTA, cardiac CT comes in. You can have it without contrast,
Okay.
or you can have it with contrast. And what we've sort of been describing and discussing through the majority of this podcast is the cardiac CT with contrast.
Right.
That's an injection, and we give the medicine metoprolol and nitroglycerin, and this kind of thing.
Yeah.
Before we do the contrast version, we do a scan of the heart, but no contrast.
Okay.
So, in the case of the contrast study, we do both the non-contrast. So we do a picture with no injection.
Okay.
And then we do a picture with injection.
Okay.
You can actually do this test just with the non-contrast version, and that's called a calcium score.
Okay.
And maybe a lot of people have heard of coronary artery calcium scoring. Some people call it CT, calcium score. Some people call it a CAC score for coronary artery calcification.
Okay.
CAC score.
CAC.
You can just do that, and sometimes doctors will do that first if you have an elevated risk of having significant coronary plaque.
Okay.
And that test is obviously less complicated. You just come in and you lay on the scanner for a few minutes, and we get the views of your coronary arteries, but it only looks at the calcifications. Okay. So you don't get the full.
So you're not like looking at the
characterization.
Arteries. Right.
But if you have no calcium, the chance of you having any kind of significant blockages is pretty small.
Okay.
But if you have calcifications, your doctor will then say, listen, you've got calcifications. That means you have underlying coronary artery disease.
So then you would move on to the next phase.
Depending on clinically what the cardiologist or your primary doctor thinks. Like some people, if your calcium score is very high, that's enough. And you're asymptomatic.
Right.
But let's say your calcium score is high and then you have some weird stuff going on. Then you want to do the definitive test.
Okay.
So, some people have described this calcium score test as the mammogram of the heart, because it's sort of the first step looking for calcifications that would maybe indicate something else as bad is going on.
Yeah. Yeah. This would be like the first line. This one, the coronary CTA.
That's right. And it's just so that a lot of times people will use the coronary artery calcium score as a initial screening test. Yeah. To kind of put you in a category. Yeah. And, just see what's going on. I mean, again, another very good test.
Yeah. And this is really the test that people should be asking their doctor if they should. Yeah.
And coming back to like who should have that test. I mean, honestly, almost everybody.
Yeah. Like over the age of what?
Yeah. Probably, for men 50, and for women, 55.
Mm-hmm. Yeah.
There's a whole way that, again, that we risk stratify people to decide who should get a calcium score and who shouldn't. So you should talk to your doctor, because it
Yeah.
really depends clinically on where you fall.
Mm-hmm.
But it's a very easy test. There's no injection.
Yeah.
There's a small radiation dose,
Okay.
and that sort of why it's also called mammogram of the heart, because it's very similar to the amount of radiation you get for a mammogram.
Right.
So
right. Which
the
is
risk is extremely
yeah.
small, and
Yeah.
it's very easy.
Knowledge is power.
Yeah.
Right. It's worth it. Okay. This was awesome. Thank you so much.
you.
Thank you.